क्या लाइव?
डॉक्टर ललित है क्या सुनील?
नहीं सर।
ठीक है, so good evening all. So we are back with the next class of our retina module, and uh, with great pleasure I welcome our speaker today, Dr. Raju Sampangi sir. And sir is an alumni from RP Center only, and he has kindly agreed from his busy schedule to take this lecture. Thank you so much, sir. So before moving on to the introduction to today's speaker, I would like to thank and appreciate Professor Lalit Verma, sir. And sir, and he has been a part of this Retina module, and he has helped us in designing the program as well as the speakers for this program. And Dr. Anupam Sachdeva, sir. The sir is co-director of Institute of Child Health at Gangaram Hospital, and he is the in charge for ANBI, with which recently we have got that association. And of course, Dr. Anita is there. She is going to coordinate between ANBI and DOS, and she is there in almost all our talks in this year. So coming to the speaker today, Dr. Raju sir, as I said, he is an alumni from RP Center, AIMS, New Delhi. He has published several papers in various international and national reputed journals, and again he was one of the associate editor of DOS Times, which now I am looking after. And thank you, sir, for your services for DOS. And he is the chief editor of Chakshu, the Journal of Kerala Karnataka Ophthalmic Society, and he has conducted several instruction courses. You must have attended one of his in any of the AIC meeting. It's a very interesting course on OT disinfection and sterilization, which is an unique topic. And another interesting aspect is sir is quite expert in this HD recording, 4K recording of surgical videos, and even he won an award for the abstract in Retina World Congress on this similar topic in Florida, USA, 2019. And he has a lot of work on video recording, and that has been also acknowledged in Survey of Ophthalmology, one of the most highly cited review journal. So with this, I'll invite sir. Sir will be speaking on diabetic macular edema today. And sir, now you can share your PPT and we can start the lecture.
Yeah. Thank you, Praful, for that kind introduction. It's always a pleasure to be give back something to DOS, and DOS is one place where we all started our career, and we were always looking forward to the DOS conferences whenever it happened when we were in our postgraduate days. So with that, I would convey also my respects to Dr. Lalit Verma sir, who has been my mentor and who has also designed this wonderful program for the postgraduates. I'll be speaking on a very important topic that is diabetic macular edema. And as you all know, this is one of the most commonly encountered problems that you will see in your day-to-day practice, especially if you're a retina doctor or a person taking care of retina. So this is the brief overview of what I'll be speaking. We'll just go through the introduction, pathophysiology, and we'll look at the various classifications that we have in this diabetic macular edema. We'll look at the past and we'll look what is the current scenario. We'll also take you through the management of the diabetic macular edema and how to treat these patients in a holistic way. If you see, it is the most common cause of vision loss in patients with non-proliferative diabetic retinopathy. But remember, it can be seen in any stage of diabetic retinopathy. DME can occur in patients with mild NPDR as well as with very severe or proliferative diabetic retinopathy also. And these patients may experience substantial vision loss from the thickening that is happening in the center of the macula. Diagnosis is made when you have a thickening in the macula, and this has to be made clinically on slit lamp biomicroscopy using a 90D or a 78 diopter lens. And DME may be associated with hard exudates, which will give you a clue that there is some kind of an edema, which are actually precipitates of plasma lipoproteins that may persist even after the DME resolution has happened. So what these exudates tell you is that this pathology has been happening in the macula for some time, and it is not just of recent onset. Although the patient may tell it is recent onset, but this tells you, the exudates tells you that this pathology has been there for quite some time. Now, if you look at the pathophysiology, so the hyperglycemia will lead to the various biochemical and molecular abnormalities, which will lead to increase in glycation end products, which results in hypoxia, inflammation, and oxidative stress. The increase in inflammatory markers is seen because of this, and these inflammatory markers are the one that is being targeted in the treatment of diabetic macular edema. So understanding the pathophysiology helps us to understand where a particular drug is acting to reduce the inflammation or the VEGF load, and taking care of the edema that is there, which is the main reason for the edema to happen in the first place. This is a simplistic picture showing you how the things are happening. So you have the microorganisms which are leaky, or you may have the damaged capillaries. These will lead to the exudation that is happening, and these exudates will be collecting in the retinal layers, leading to the swelling. So what you see clinically can also be demonstrated angiographically and on the OCT, which will look something like this, which I'll deal with in greater detail later. So if you are diagnosed diabetic macular edema, what next? Well, let us see the stepwise management. The first thing we need to do is to classify the macular edema. Then FFA would be preferable, then treat it. And the next step is to monitor these patients and to retreat, because it's not a one-time affair. This treatment has to be continued for not months, years together in these patients who have diabetic macular edema. And this is the first thing that you need to counsel our patients whenever you see a patient of diabetic macular edema before you start treating them. As far as the classifications are concerned, so you have the clinical classification, then FFA-based classification, then the OCT-based classification. Clinically, some simple ways to classify them are whether the diabetic macular edema is present or absent. This is mainly for screening purposes, so that whenever you see a patient with diabetic macular edema, you know that this patient requires additional care, so that he's sent to the appropriate doctor with facilities, so that that is being taken care. As far as the severity is concerned, some people would classify them as mild, moderate, and severe diabetic macular edema. This is the clinical classification. But what we learned 20 years ago when I was a student was this classification. This is the classification that we used to learn by heart, and this used to be always asked in our exams. So what is the classification of clinically significant macular edema? And everyone should know this from the historical perspective. However, we don't use it now. So what are we doing now is that we are classifying the edema based on the location, whether it is center involved or non-center involved. And in the center involved diabetic macular edema, it is further classified as center involved diabetic macular edema with reduced vision or patients with good vision. The good vision, most of the criteria is either taken as 6 by 12 or 6 by 9, and anything better than that would be considered as central non-diabetic macular edema with good vision. So how are you classifying it as center involved? It is mainly based on the OCT, and it's not clinical classification. It's an OCT based classification, and the central subfield thickness is taken into consideration, and if it is more than 300 microns, then it is considered as a center involved diabetic macular edema. Apart from the location of the macular edema, you also have to use the OCT to look at the morphology. So the morphology of the edema could be a diffuse edema or a cystoid edema, and you also look for a subretinal fluid. So your diffuse edema means a sponge-like swelling, which is generalized, heterogeneous, with mild hyporeflectivity, while a cystoid macular edema would be the presence of intraretinal or round oval cystoid areas of low reflectivity, which are typically separated by high reflective septae. This is the morphological classification that we are seeing here. Then you also look at the serous detachment. These are focal localized detachments of the neurosensory retina just below the foveal area you may see. Then the other thing that we also need to look at is the vitromacular interface abnormalities. So why it is important to understand this is any patient who's got a vitromacular interface abnormality may not be a good treatment for pharmacological treatment, and these patients would require probably a surgical treatment if feasible in these patients. Then coming to the FFA, this is what we used to do during our PG days. So we used to do FFA for all our patients, and we used to classify them as focal edema, diffuse edema, and sometimes mixed edema. So this classification, what we used before, is not used nowadays. We don't use this classification and don't treat the patient based on this. However, if the patient has a non-center involved diabetic macular edema, that is basically a focal macular edema, then we still go ahead and do an angiogram to note the leaking microaneurysms and treat these specifically to achieve the good results for these patients with diabetic focal macular edema. Now, do you really need to do FFA? The answer is preferably yes. That is because not only the edema part that we are looking at, we are also looking at the other factors which are responsible for decrease in vision, the ischemic maculopathy. Then it will also give us an idea of the peripheral CNP, and also it will help us to rule out early PDR. So whenever you're doing uh, a study, angiographic study, to rule out the macular ischemia, and you have to look at the FAZ, use the peak phase angiography photos to interpret the macular ischemia. Now, other scenarios where it could be helpful would be in patients who have undergone cataract surgery who previously had a moderate NPDR, and post surgery the patient doesn't improve or complains of blurring of vision, then we need to rule out whether it is a worsening of the diabetic status or whether it is a pseudophakic CME. This is where the uh, angiography would help us. OCT will show edema in both the patients, but a patient who's got a cystoid macular edema will have a hot disk, wherein that means in addition to the macular leakage, there will be leakage from the disk, which confirms that this patient has got a cystoid macular edema, and we need to treat these patients with steroids, whether topical or intravitreal. Most likely, you will be treating with topical steroids. So we need to step up the steroids and not to initiate any intravitreal anti-VEGF treatment in these patients if we have a disc leak. The other role is in patients who have astroidalosis. So sometimes it becomes very difficult to visualize these patients. However, an angiograph will help us to identify the various disease processes that are happening here. As you can see here, NVE is there, which is very easily picked up on angiogram, but it's very difficult to pick up on clinical photography. Coming back to our management. So how do you manage these patients? So patients in it is important to understand that we all order OCT and FFA for patients whenever we see patients of diabetic retinopathy. But more important is to understand that we need to look at their systemic status. What are his blood sugars? What is his HbA1c levels? Make sure that you've got a kidney function test and urinary microalbuminuria is there or not. That also has to be ruled out. The fasting lipid profile and the hypertension. These are all actually combining together and causing diabetic macular edema. And if these things are not taken care, which is the primary cause for the edema in the first place, then however much treatment you give, it will not lead to very good results. So before you start treating the patients with any kind of a treatment, intraocular or lasers, make sure that the patient has got a good systemic control, his blood pressures are under control, and the nephropathy has been ruled out. Now, what we used to do, as I told you 20 years ago or 2 decades ago, is that we used to classify these patients as clinically significant macular edema. We used to exclude ischemia by doing a FFA. Then, if there was no ischemia, then if it was a focal edema, we used to do focal photocoagulation. And if it was a diffuse edema, then we used to do a grid photocoagulation. This is how we used to treat these patients about 2 decades ago. But what we gave our patients was just stabilization. So ETDRS results for DME are a history now. They are no longer the gold standard. This was the gold standard 2 decades ago. They are not the gold standard now. Why? Because they help to reduce the risk of moderate vision loss by 50%. They were effective in only preserving the vision, but they are less successful in restoring vision. Visual acuity improved in only 3% of our patients. So what changed? So after 2004, what happened was the era of intravitreal pharmacotherapy started, and it initially started with IVTA. Then after that, we had a lot of studies which came up. Initially, the IVTA, that is intravitreal triamcinolone acetonide, was used, and but it was not possible to replace laser at that time, and laser was still better than IVTA. That was mainly because of the cataract that developed in these patients. But however, in 2012 onwards, the era of anti-VEGF started with various agents like Accentrix or Lucentis, as you call it now, or ranibizumab, and the bevacizumab, that is the Avastin, came into picture at this time. And from 2010 or 12 onwards, it has been the era of intravitreals, and they have dominated the scene even till today. So anti-VEGFs with or without laser were found to be better than laser alone. And the diabetic management, diabetic macular edema management today is based on all these studies that are there, which were done a decade ago. And these are the landmark studies on which we base our anti-VEGF treatments. Now, if I have to go into all these studies, it's going to be very, very confusing, and the chart would look something like this. What I would try to do in my next few slides is to break this down for you so that you understand the main parts of these studies and what is the take-home message of these studies. If you see the drug that was used, the ranibizumab, these were the six studies that were there. The READ, RESTORE, or DRC are not studies, and the RISE, RESOLVE, and RISE studies. In the first three studies, Lucentis was compared with laser, while in the next three studies, Lucentis was compared with the sham injection. Now, what it showed finally was Lucentis alone or Lucentis with laser was better than laser alone. So what these studies showed was superiority of anti-VEGF, that is the ranibizumab, over the laser. And they found that doing laser alone was not sufficient. It is better to give anti-VEGF injections in these patients. And when you compare between Lucentis alone and Lucentis plus laser, there's no additional benefit with laser in these patients. As far as the Avastin is concerned, Avastin was better than laser alone. Again, the same results of what was shown in the ranibizumab was also reflected in the Avastin study also. And when you compared with Avastin plus laser alone and Avastin plus with laser, it was found that again there was no additional benefit of giving laser in these patients. So treating these patients with anti-VEGF was found to be good enough. Then you started having the later in time, you have the Vivid and Vista, which compared laser alone with aflibercept. And again, it was found that aflibercept was better than laser alone. Next, the new drugs which have come into picture is the brolucizumab, also called as Pagenex. The commercial name is Pagenex. The Crystal study and the Kite study again compared brolucizumab with aflibercept in this case, and what it has shown is that brolucizumab or Pagenex showed robust visual gains and anatomical improvements with an overall favorable risk benefit ratio in patients with DME. However, this is a new drug that we are all trying, and there are some concerns. This is another study that involved Pagenex or brolucizumab that's called as the Kingfisher study. Here it found that when they compared, there was no difference between the visual outcome between the aflibercept and brolucizumab. But they, however, noted that there was superior anatomical improvements in patients who were treated with brolucizumab, meaning to say that patients who were treated with brolucizumab or Pagenex had much better drying up effect or reduction in the macular edema after treatment with brolucizumab compared to aflibercept. Although there was no clinical difference in the visual outcomes. Now, why it is important to understand the importance of brolucizumab is that although you have good safety, good efficacy, and it can reduce the treatment burden in patients with DME, the effect of Pagenex approximately lasts around 12 to 16 weeks. So, what is required on a monthly basis for other agents can be shifted to a 3 monthly or a 4 monthly injections with Pagenex. Hence, it will lead to reduction in the treatment burden for the patients with increased in the treatment intervals while confirming both functional and anatomical outcomes. One drawback of this drug is the risk of intraocular inflammation, retinal vascularitis, and retinal vascular occlusion. This has to be explained to the patient. The approximately around 4% is the risk that has been shown in various studies. 2 to 4% is what has been shown in various studies. There's one more drug that is in the market now, that is the faricimab, which is a bispecific monoclonal antibody which inhibits both the vascular endothelial growth factor and the angiopoietin 2. And this has a dual mechanism of action compared to other drugs, which only target the VEGF. Now, in the subgroup analysis of these two studies, this ESOMITE and the RHINE trials, it was found that it has got comparable visual acuity improvement with respect to aflibercept. However, it had a greater reduction in retinal thickness, and these patients required fewer number of injections compared to aflibercept. However, the cost is a prohibiting factor in our scenario, in the Indian scenario. Hopefully, when the cost comes down, we'll all be able to use more frequently these drugs in our patients. Now, what is the difference now with the anti-VEGF compared to what we were doing with the laser? As I told you before, laser can help maintain vision in 50% of the patients, and visual improvement in by 10 letters happened in only 3 to 7% of our patients. So what anti-VEGF is doing now is to improve the vision by about 10 to 15 letters in about 30 to 60% of the patients. So this was what was missing with the laser treatment, and this is what we have achieved with the newer anti-VEGF agents. And because of that, the patient's quality of life has improved. So if you look at the standing now, the lasers have been relegated to the third spot. You have the anti-VEGFs as the crowning king, followed by steroids. Now, should I treat all patients of DME with anti-VEGF? That's the question that we need to face when we will face when we see patients with diabetic macular edema. The answer is no. First is to ask the question whether the patient has got good vision or vision less than 6 by 9. If the patient has got good vision better than 6 by 9, one can just observe these patients with a good diabetic and hypertensive control, review these patients at monthly interval, monitor the vision and the macular edema. However, if the patient has got a vision which is less than 6 by 9, then we can consider the pharmacological treatments. So if you have a patient with good vision, in case you want to treat these patients, it was found that whether you give the patient anti-VEGF injections or you do a focal laser or you just observe them, all of them were equally good. So it is better to wait and watch these patients who have got good vision. When it comes to uh, treating patients who have got vision less than 6 by 9 with central involved diabetic macular edema, then we have a plethora of choices, as I told you. You have the ranibizumab, that is the original molecule that was approved, that is the Accentrix or the Lucentis. Then you have aflibercept or the Eylea. Now we all have access to the biosimilars, and we are proud that many of them are manufactured in India, like Razumab, Raniase, and you have the drug which is not approved but still very widely used, that is the bevacizumab, and the newer drugs, that is the brolucizumab and the faricimab. As far as the steroids are concerned, there are three main treatment options that we have. That is the dexamethasone implant, a triamcinolone injection into the eye, and the fluorescein stenoid implant. Now, again, when we have to choose the treatment, whether one should choose anti-VEGF or to choose steroids, we are left with a lot of questions. Apart from choosing anti-VEGF or steroids, then which anti-VEGF and which steroid is a question that comes to our mind when the patient is sitting in front of us. But finally, the scenario is who chooses. So whether it's a doctor who makes a choice or it's the patient who makes the choice, this is very important in the Indian scenario because the cost is an important factor. And when you counsel a patient of diabetic macular edema, it is not a one-time affair. The patient has to take the injections on a monthly basis for long term. So it is very important to take the patient into confidence and make them understand that just taking one injection of whether it's a very costly injection, just taking one injection will not work. It is better that the patient has a continuity of care and chooses a injection which he can afford to take continuously on a monthly interval. This discussion has to happen with your patient whenever you're treating diabetic macular edema. Now, as I told you, if the vision is between 6 by 12 to 6 by 9, when we compared, all anti-VEGFs work equally well. However, if the vision is poor, that is the baseline vision is poor and less than 6 by 12, then Eylea or faricimab works better in these patients. So if you have a patient who's got poor vision to begin with, then you can consider treating these patients either with aflibercept or faricimab or probably Pagenex also to begin with. These patients, if they can afford them, then you can start treating these patients with these drugs. So if you have got vision which is less than 6 by 12, then you consider aflibercept. Now, if you compare the safety profile of various anti-VEGF treatment in diabetic macular edema, all of them have equal safety profile. So there's nothing to worry, including bevacizumab have equal safety profile. Only thing that we need to understand with respect to bevacizumab or Avastin, it's an off-label use, and you need to take appropriate concern for these patients when you are using Avastin. Now, with the easy availability of the biosimilars, I think most of us have switched over to the use of biosimilars in these patients, and the use of Avastin is steadily decreasing. As far as steroids is concerned, the approved is the dexamethasone implant, and however, the most commonly used steroid is the triamcinolone that we all use because of the cost factor. Now, when you are treating patients with uh, steroids, again, it's important to make this case selection or optimize the case selection here, whether it's a patient is a phakic or a pseudophakic. And when you want to treat, it is preferable to treat patients who are already undergone cataract surgery, because in that way we are removing a confounding factor of development of cataract in patients who are treated with steroids. Now, before you treat these patients who are pseudophakic, check whether these patients are having a steroid response or a non-responders by giving a steroid challenge test. So if you give a steroid challenge test for 3 weeks, if the IOP doesn't increase, then you can very well safely inject the intravitreal steroids for all practical purposes. So what is important is to, before you start treatment, is one should have an honest communication, then uh, discuss with them the risk, benefits, and alternatives that are there in the treatment. Tell them about the need for multiple injections and long-term follow-up. Importance of systemic control has to be emphasized at every visit, and you keep asking the patients, well, what is your blood sugar levels? Show the records, show the reports. What is his HbA1c levels? At least for 3 monthly interval, you need to make sure that you educate the patient that systemic control of diabetes is more important than taking anti-VEGF injections. That's what I tell my patients. So if they control their blood pressure and diabetes, the number of injections that are required over a long-term period may reduce. There are some pharmacological agents which are being studied based on the various uh, mechanisms of pathophysiology that I discussed. Some of them considered for treatment systemically are enalapril, losartan, and fenofibrate. Fenofibrate is especially useful in patients who got exudative maculopathy, wherein you have a lot of lipid deposits in the macula. Now, should we laser? If yes, when? As I told you, when we have a fovea involved diabetic macular edema, it's better to start with anti-VEGF injections and then do laser. So in the DRCR group, they studied this question, whether you should do laser immediately or you should defer the laser. So if you do give injection and do a laser immediately at 1 or 2 weeks, that was called as the prompt laser. And the deferred laser was those patients in which patients were given Lucentis injection on a monthly basis, and after 3 injections or after 3 to 4 injections at 24 weeks, the laser was performed. And when you deferred the doing the laser, what happened was the number of patients who required laser also reduced. So only 46% of these patients required laser in this group. So what was noted was in the long term, it was said that when the initial studies came up, it was found that it is better to defer the laser. However, a 5-year results in the long term showed that there was no difference between the prompt versus the deferred laser group. That is exactly the opposite of what they told in 2012. However, from the clinical perspective, what we have noticed is it is better to reduce the edema with anti-VEGF injections and then to start the treatment initiation for with laser for diabetic macular edema if it is required. Now, what was important is that even though we give monotherapy in various studies, majority of these studies, if you see the small print, each group was allowed to have a rescue focal laser after 6 months if they had a persistent DME. And when we look at the data there, 37% of the patients with aflibercept, 46% of the patients with ranibizumab, and 56% of the patients who were treated with Avastin required laser. So what it means that even in study conditions where follow-up is carefully monitored and patients are coming in every month, still patients did require focal laser. So you don't throw your laser machine out, still it will be required for many of our patients, at least around 40 to 50% of the patients may still require laser in the long term. Now, again, there are two laser treatments that are available. One is the yellow laser, other is the conventional, that is the green laser that we all use. So this is the yellow laser treatment wherein the whole macula is painted with very invisible spots, and you'll not be able to make out these spots on when treated with yellow laser. But however, if you see these treatments and comparison, it was no large clinical differences were found when you use a yellow laser or a green laser. So it is still the choice of the surgeon. So if you have access to yellow laser, you can do it, but that doesn't mean you need to do only yellow laser. Even the green laser would work equally well in these patients. This is a patient of focal macular edema, which has been treated with focal laser. What is important to note is the laser has to be very, very minimal, and you should be able to see barely minimal change in your retina in the long term. If you are seeing a very heavy burn, then it is not correctly done laser. The laser has to be very minimal and a focused laser based on the angiography. There are now various laser treatments that are coming up as to increase the uh, surgeon comfort, as I would say, wherein the all the focal aneurysms are marked, and these are marked on the photograph, and the machine delivers it to the retina without you needing to focus on the laser to be given. So this is all going to be automated. However, it comes at a very huge cost. There are other various novel pharmacotherapies in DME based on the mechanism of action. These are the drugs that are probably that we may see in the future, whether it could be systemic or intravitreal. But a lot of research is going on towards treatment of this very important problem that we all in face day-to-day problem, day-to-day practice. Then coming to the last is, as I told you, is the when you have a patient with diabetic macular edema with retromacular interface abnormalities, it is important that you look at this OCT, and whenever you see a OCT like this, which has got a thick epiretinal membrane, which is pulling up the retina, the treatment with the anti-VEGF injections is likely to fail in these patients, and these patients would require a surgical treatment. So the surgical treatment in these patients, as you can see here, is a vitrectomy You can see a thick hyaloid here in this patient, which was not allowing the macula to settle down. Here we are doing a dissection of these membranes using a 24 gauge needle. An opening is created, and the membrane which is there on the macula is cut. It's again important here not to deroof the foveal area. We try to work around the fovea and then trim it rather than pulling it in one go that we usually do when we have a epiretinal membrane. So this is because in patients with DME, they have the fovea being very thin, and sometimes it can cause a iatrogenic macular hole. Here, we are trying to dissect out all the membranes, and this is usually followed by peeling of the the internal limiting membrane after peeling the epiretinal membrane. So this would lead to restoration of the foveal contour in majority of the patients. However, it's important to understand that these patients will maintain the vision and will mainly help in further deterioration of the vision in these patients. So the take-home message, although data from clinical trials are helpful, clinical management of diabetic macular edema should be based on individual patient. Main thing is to look at is the systemic control, then look for any proliferative disease that is there that has to be taken care together with it. And the fellow eye also has to be seen and treated accordingly, and the continuity of the care has to be explained to the patient at the very beginning so that he is taken into confidence and he follows up with us and takes the treatment regularly so that we can give a better quality of life by reducing his macular edema. Thank you very much.
Thank you so much, sir, for that wonderful lecture and that comprehensive outline that you provided to the students. I'm sure they're going to benefit a lot from that. The flowcharts were indeed so really helpful. I think not just the residents, even they are helpful for us who are non-retina specialists to help them manage the patients. So there are a few questions that have come up. One of the resident has asked that there is a patient. Is there any role of cutoff of the central macular thickness in deciding to whether to go for anti-VEGF or not?
Yeah, most studies, see, basically, most studies take a 300 microns as the cutoff. So if the vision is poor and the thickness is more than 300, then we'll go ahead and treat these patients. So 300 microns and on the central subfield macular thickness. So not on this one, on the macular cube scan, which are OCT that you're using, a 300 micron thickness is what is the commonly used cutoff. Although some studies have taken a higher cutoff, but majority of them have a 300 micron cutoff.
So is there any cutoff for difference in the CMT between the two eyes also that you look at when treating these patients?
No, the each eye. That for that eye, whether it is more than 300 or not, in the central subfield thickness. That's it.
So there's another question. What is the role of topical NSAIDs in presence of macular edema and poor vision? Whether to go for anti-VEGF or give them a trial of topical NSAIDs?
Topical NSAIDs for all practical purposes would not work. Treatment is intravitreal. You need to give intravitreal injections in these patients. If the patient poor systemic status is poor and you are not able to give them in the meantime, you can start them on non-steroidal anti-inflammatory medicines, but they rarely work. They rarely work in real diabetic patients. But if the patient has been a patient of cataract surgery and you are seeing him in the post-op, as I told you, in these patients it will help. That is mainly it will be treating the post cataract surgery inflammatory cystoid macular edema, which is probably got aggravated after the cataract surgery. That component can be taken care. Sometimes I also add steroids ointment at night time in these patients if they have a persisting edema after cataract surgery, and which I feel is not because of diabetes and mainly inflammatory in condition. Especially you need to look at the uh, cells on good slit lamp biomicroscopy by doing a good slit lamp biomicroscopy. And if you find cells in the antechamber, that means there is inflammation going on, and these patients would probably benefit from an anti-VEG, from a steroid or a NSAID. But
So
otherwise, the diet
which
is
topical NSAID do you prefer in these patients?
all of them
Neperfuline.
work well. All of them work well. All of them work well.
Okay.
Whether it is your Nepafenac or your Brom,
Bromfenac.
all of them work well. There's no difference between the two.
Okay.
There's no difference.
So there's another question. A patient has cataract and DME both. With NPDR with DME. So in this situation, whether to go for cataract surgery first, anti-VEGF or combination, or anti-VEGF followed by cataract, what is the sequence to be planned in these patients?
So it all depends on the various um, factors that are causing the loss in vision. Now, whether cataract is the primary cause, whether edema is the primary cause. That's the first question. So if the edema is the primary cause, then you can always defer cataract surgery. Okay. But if the cataract is so severe that you're not able to see the retina, then I would probably do a combined treatment for these patients. We'll do cataract as well as the anti-VEGF in the same sitting. But if the cataract is minimal, I would usually try to stabilize the retina first with anti-VEGF, a couple of anti-VEGFs, then take them up for surgery. But either way, it works. Only thing that you need to communicate to the patient is they will be under the impression after the cataract surgery, everything will be okay. So that communication is the most crucial thing, that I'll do the cataract surgery, but after the cataract surgery, the diabetic care is going to continue and he needs to take injections. And you need to take a special consent in these patients, make them write in their own handwriting that you have a retinal problem and the visual recovery will depend on the retinal capacity. This has to be communicated. Otherwise, what happens? The expectations after cataract surgery is very high, and they compare themselves with other normal patients, and they will be patients will be cribbing a lot in your OPD if their results are not as per their expectation. So you make sure that you let them understand that they have a retinal disease and it has to be communicated correctly with proper consent. That is very important in these patients.
Rightly said, sir. The consent and counseling part is very important when you're treating these patients, because the basic understanding of the patient is really important when you're treating this patient. So there's another question by a resident. What is the definition of recalcitrant DME? Because my consultant is never satisfied with what I say.
It's very difficult to make a definition for that in real sense. In clinically, we would say that if you've treated these patients with at least 3 to 4 injections and still they are not responding, we would consider this as recalcitrant diabetic macular edema. That means it is not responding anyway. Like sometimes we have patients who have 400 or 600 micron thickness, and we have given them 3 or 4 injections, then they don't respond, and that's when we plan to switch over to another drug.
Okay. So basically, if you're treating with anti-VEGF in these recalcitrant DME, what are the treatment options that you have for the management of these cases?
As we said, it all depends on what we begin with.
Mm.
So in the Indian scenario, we basically begin usually with Avastin or biosimilar. And if the biosimilar doesn't work, then we tend to counsel them for a higher, preferably an aflibercept in these patients. If they are not able to afford, then we are left with no other choice but to go back to steroids.
Steroids.
So some patients who do not respond to the anti-VEGF sometimes respond to the steroids, but there are some patients who don't respond to any of the medications, and those patients sometimes vitrectomy has been tried, but again the results are not very great.
Okay. I think, sir, these are all the questions from my end. Dr. Anita. Anita, ma'am, if you're there.
Okay, Pranita, can I just interject here?
Hi, Pranita. Yes, I'm here.
Ma'am. Yes, sir. So you want to ask some questions?
No, no, actually, the about the recalcitrant. Uh,
Mm.
Hello, am I
Yes, sir.
audible?
Yes, sir. You're audible. Please speak,
The
sir.
question about that recalcitrant macular edema, no, there is an article in DOS Types where Dr. Amod Gupta he had defined it as you have given two injection and the thickness is still more than 400. Then that's how he used to define recalcitrant macular edema. And I don't know how far this is accurate. Dr. Raju can add on to that. And
That's what
second,
I
there is
said.
a
So
simple question by
usually
one of
around three injections is what I take.
Three
Two
injections.
injections or three injections on. That's what I said. If you're giving the injection on a monthly basis, even after two or three injections, I take it as three or four injections basically. So I give three injections and then only can say that this patient. But it depends. If you are not seeing any response after two injections, you can label it as recalcitrant edema. In these patients, we'll be thinking of other treatment options.
Mm.
the
I
second
think that is.
question is about that steroid challenge test. So which steroid? And I think you said it's already 3 weeks. So which steroid you would prefer for steroid challenge test?
I usually give a dexamethasone only, topical dexamethasone.
Okay, so there is one question from my residents. If the patient is from a far place and cannot come back for follow-up, is it a good idea to, it is advisable to do laser or DME not involving center?
Not involving center, there is no question of not doing the laser. You can do the laser. Only in patients who are having center involved diabetic macular edema is when we don't do a laser. But if it is not center involving, then you can always do a
I
laser.
think I think he must have get confused. The question would have been for center involving macular edema. If the patient cannot follow, come back for follow-up, so can we go ahead with laser?
If you don't have any other option, you can still do a laser because then you will be going back to what we did 20 years ago. That's all. So it will help reduction in loss of vision, moderate loss of vision by 50%. That's it. The patient is not going to have improvement.
This is a Viva question asked to one of my exam going batch, sir. So if
Okay.
somebody is having macular edema, diabetic macular edema, so is it advisable to go for investigation or simple clinical diagnosis is enough?
Now, if you go by standard of care, okay, if you go by standard of care, the central macular thickness and the central diabetic macular edema is based on OCT itself. So it has to be OCT at least has to be done in these patients to confirm and to proceed treatment. Now, what happens if you treat this patient without a OCT and the patient ends up having a endophthalmitis after anti-VEGF? You are going to be in a soup because
Yes.
the court is going to ask you, where is the proof that he had a central involved macular edema? So clinically, yes, but it is very important in this era that we document what we are seeing and treat accordingly. That because that is the standard of care. Because that's the standard of care. That's what I would say as an answer.
Thank you. I think the resident got his answer. Pranita, now you can conclude. Thank you, sir. The talk was awesome, excellent, and we are going to invite you for further more talks in DOS PEPs. The students really loved it.
Thank you. Thank you so much.
This is a small appreciation from our side, and if you will be giving a frame certificate in our annual DOS, and it's on 13, 14, 15 June. I hope you will come for annual DOS.
Yeah. Probably I'll plan to come. Thank you. Thank you, Praful and Pranita. You people are doing a great job. It's such a nice thing to see you all active and taking so much good care of our postgraduate students. And congratulate the whole office bearers of the DOS on this um, program that you have devised for the students. Thank you so much.